My name is Liam Martin. As was mentioned, I am a rheumatologist. I just retired from the University of Calgary at the beginning of July, and I'm now working at Calio Health here in Calgary. These are my presenter disclosures. I've been working with pharmaceutical companies, not directly, but indirectly for years, and I've sat on advisory boards again for years. They like to hear some bullshit from an Irish rheumatologist who gives them straight talk, I think, some of the time. So what I'm planning to do today is talk to you about how, as a rheumatologist, we address patients' needs and concerns when they present with joint pain. We obviously take a thorough history. We examine patients very carefully, and then we come up with the management plan, which is developed with the patient's input. So rheumatologists are referred patients mostly because they have musculoskeletal pain. Sorry, Jeff, I'm advancing my own slides here. Can you advance to the slide, A Day in the Life of a Rheumatologist, please? Yeah, I'm seeing, oh, so you have, it's up in the top corner, yes. Okay, so these patients are referred in because they have joint pain. The pain can either be in joints, around joints, or in muscle, or in all three areas. And in most instances, patients have been seen by their family physician who has tried them on a variety of pain medications and sometimes including narcotics without much effect. So next slide. So patients will tend to complain of difficulties doing their daily activities. They have difficulty doing their job because the pain interferes with their functional capabilities. They also have many non-musculoskeletal complaints. They feel tired all the time. They don't enjoy life. They have sometimes developed difficulty with thinking. They can't remember items that have been part of their day-to-day activities, and they're not enjoying life. And on many occasions, they will have had a blood test done. We see this screening for patients with rheumatic complaints, a rheumatology screen, which is the bane of most of our lives because, as you'll see, I tend not to order tests unless they are indicated. So patients will come in, they've had a positive rheumatoid factor, or they've had a positive anti-nuclear antibody test, which is seen in patients with systemic lupus, or they'll have a slightly elevated inflammatory marker profile in their serum, and they will be told that they have a condition called polymyalgia rheumatica. So let's consider a case, a typical patient referral to the clinic, a 30-year-old woman who's referred for assessment of joint pain. She's had sore joints for about 3 months. The pain has been there intermittently. She feels tired all the time. She has difficulty doing activities. She has difficulty getting out of bed in the morning because she's so stiff. A shower gives her some symptomatic relief, but not complete relief. She's not very quick at getting dressed and getting out to work. She has been taking some over-the-counter pain medication, but has had very little response to any of the medications that she has tried. She has had some prescription medications for inflammation from her family physician, which have not helped. And she's had some laboratory tests done, and one of them shows that she has a positive rheumatoid factor, weakly positive rheumatoid factor. And then the patient's referred for a possible diagnosis of rheumatoid arthritis. And unfortunately, this diagnosis is often mentioned to the patient, who will then go off and look up what rheumatoid arthritis is and what the consequences to them will be with rheumatoid arthritis. And unfortunately, again, there are many descriptions of rheumatoid arthritis which are what I would describe as old. They do not take into account the approach that we have to rheumatoid arthritis now. So you have a patient sitting in front of you who's very afraid of what the future holds. The other type of patient that can come in with musculoskeletal symptoms is a patient who is known to have rheumatoid arthritis and who complains of increased stiffness and joint pain. So they've had their disease for many years. They've been doing extremely well. And now they're feeling as if the medications that they have been taking are not working as well as they used to. They can be on any of the older disease-modifying therapies like methotrexate, or they can be on the newer biologic therapies, which have been around now for just over 20 years. Or we see a patient with systemic lupus who presents with increased fatigue and joint pain in their hands and feet, or joint pains in any joints, or muscle pain. And the concern there again is that their systemic lupus is flaring. And in both of these patients, there is a tendency before they're seen by their rheumatologist for their medications to be increased, particularly steroids, because steroids can be very effective in managing flares of disease, but we don't like to leave patients on those long term. But oftentimes the patients will come in and they've been seen at their family physician's office, or they themselves have a supply of prednisone, for example, and they will start taking it at a higher dose than they are prescribed to see if this will help. Another situation is the patient who has ankylosing spondylitis, which is an inflammatory disease that affects the spine and sacroiliac joints and can also increasing back pain. And this can be very difficult to sort out because there's no specific markers in the serum for patients who have ankylosing spondylitis. We depend very much on history and physical findings. And then there are patients who have other inflammatory autoimmune type diseases like inflammatory bowel disease, such as Crohn's or ulcerative colitis. And those patients, in about 15% of the time, will have associated musculoskeletal problems. And they can have symptoms that are similar to ankylosing spondylitis, or they can have peripheral joint involvement, for example, involvement of their knees, involvement of their ankles or their hands. And they do indeed have inflammatory arthritis, but they will present, even though they have been well controlled previously, with a new onset of increased symptoms. So how are these patients assessed? Well, as with everything in medicine, if you don't take a thorough history, you will be lost. It's very easy to focus on one complaint and follow that complaint down the road wherever it takes you. And if you don't take a full history, you won't know whether this complaint is present for whatever length of time. You won't know if it's associated with other complaints, which makes it very important to sit down and take a chronological history from the patient of everything that has gone on, especially for newer patients, but for patients who also have a recognized inflammatory arthritis. It's still important to delve into what has happened to the patient that has possibly led them to having increased symptoms. In the new patients, it's important to know how long they have had symptoms. The young woman I presented as the first case had her symptoms for 3 months, which would fit into the area of chronic symptoms. And the other interesting problem or question that has to be asked in situations like this is, are the patient's symptoms present all day, or do they come and go? In patients who have an inflammatory arthritis, the symptoms do not go away. They stay there until they are treated. Patients who have musculoskeletal pain, the severity or the symptoms will vary on a day-to-day basis. They'll be present on some days, they will not be present on others. In some patients, they're not present all day. So it's very important to have a history of how the symptoms present. The other part of taking a complete history, particularly surrounding joints, is you need to know which joints are affected. In rheumatology, as well in most other medical conditions, we follow patterns of symptoms, and most patients will fit into a certain pattern for disease diagnosis. So in a patient who has rheumatoid arthritis, generally speaking, they will present with small joint involvement of the hands and feet in about 75% of cases. In about 25% of cases, they will have large joint involvement. But it's very important to take a history of what joints are involved. You ask the patient if they have difficulty opening and closing their hands. Do they have visibly swollen joints, or do they feel swollen? Some patients with musculoskeletal pain without an inflammatory background often feel that their hands are swollen, but they don't see any swelling. And as an assessing healthcare professional, you won't see any swelling either. And then the other question is the range of motion affected in the joints? Can the patients put their hands, finger joints through a regular range of motion? Can they raise their arms above their heads? If their shoulders are painful, can they get dressed? Can they pull on a sweater over their heads, etc.? These questions are really important to ask patients about. And the next step, of course, is to find out how severe these symptoms are. Is the patient's functional capability affected? Oftentimes, with rheumatoid arthritis, for example, patients will have difficulty doing their daily activities. They'll have difficulty getting dressed. They'll have difficulty tying shoelaces. They'll have difficulty helping their children to tie their shoelaces. I saw a patient on Friday at clinic whose main complaint was that he was having difficulty tying up his young son's hockey laces. And anyone who's ever tied up hockey boots understands that that requires a fair amount of pressure. So he was unable to apply that pressure because he had swelling in his hands. But patients who don't have an inflammatory arthritis tend to be able to do those activities, but it hurts. You also have to ask the patient, is their sleep affected? Patients with an inflammatory arthritis tend to be very fatigued and they sleep reasonably well. Patients with inflammatory back pain, however, can wake up at night because they become stiff when they lie still for a length of time. They go to turn over in bed and the pain of turning wakens them. The other part of taking a complete history is that you must review the patient's health status. So you have to ask the patient about other illnesses that they may have had. You have to ask them about their past history of illnesses. And you have to ask them about their social history. Jeff, you can move on to the next slide. Yeah, sorry, I changed some of my slides last night. I apologize. So again, it's very important to know what other issues in a patient's health can affect how they feel. Social history is also important. What kind of help does the patient have at home? Are they expected to do all their own activities? Is there somebody there who can help them deal with their pain? It's really important to know all of these things when you're trying to make a diagnosis in a patient. Next slide. So a physical examination and a thorough physical examination, not just an examination of the affected joints, but an examination of the patient. It's really important. If you only examine the joints that is affected, you don't know what's happening in the other joints, and it's an incomplete exam. The joints are observed for redness, which is not that common, even though it's one of the primary symptoms or primary findings of an inflammatory arthritis. Swelling is really important to assess. And it takes practice to be able to do this correctly, but with experience, physicians can determine whether or not a patient has swollen joints. And then the other observation that's made in joints when doing an exam is whether or not there's joint damage. You can also feel increased temperature over joints. And this doesn't mean that the joint is so warm that you could fry an egg on it, but the surrounding skin should be warmer than the affected joints. And when you palpate the joints, they should be tender. And the range of motion is assessed by getting the patient, first of all, to make a fist, for example, if you're assessing the range of motion in the small joints in the hands. And then the physician puts the same joints through a range of motion assessment to see if the patient is blocking because they have swelling in the joint, or if the patient, when you ask them to do the motion, is not moving the joint through a range of motion because it's painful, but in fact you can, as the clinician, move the joint through a range of motion that's normal. Next slide, please. So how do you move forward from there? Well, the basis of laboratory test ordering is that you base your laboratory test orders on the history and physical examination. We like to think in most instances that about 75% of a patient's diagnosis can be made on a history and physical exam alone. And the laboratory tests are used not to find out what's going on with the patient, but in some ways to consolidate your diagnosis. Now, this isn't always the case, but you have to be careful not to order everything under the sun, because the more tests you order, the more abnormal results you're going to get, which may in fact have nothing to do with what the patient is complaining about. So it's very important to have your tests ordered and focused around what you think might be going on with the patient. I like to describe the tests that I do as being relatively non-specific and relatively specific. So non-specific tests would include simple blood counts, like your hemoglobin, white cell count, or platelet count, blood chemistry, where you look at the patient's liver function, kidney function. You look for inflammatory markers, which are really important to assess, particularly if you think a patient has inflammation, either systemic inflammation, where the whole system is inflamed, or joints. And a urinalysis is important for a number of reasons. One, in patients who have systemic lupus, they can have renal involvement, or in patients with rheumatoid arthritis, you need to know what their renal function is like before you start treating them. Some of the medications that we use can affect the kidneys. And then you x-ray the joints that are affected. And if it's one hand, you always x-ray the other hand so that you can compare. You always, in rheumatology, we do paired x-rays. So you don't just x-ray a foot, or you don't x-ray a toe. You x-ray the whole foot, and you x-ray both feet, because it's important for diagnostic purposes and for monitoring purposes to know what's going on in both feet or both hands or both shoulders when these joints are affected. The relatively specific tests include rheumatoid factor and a test called an anti-CCP antibody, which is more specific for rheumatoid arthritis than rheumatoid factor, and an anti-nuclear antibody test. So rheumatoid factor is not specific for rheumatoid arthritis. If you have a patient who has a history and physical findings consistent with rheumatoid arthritis, the rheumatoid factor can give you some information, possibly on how severe the disease is. But to order a rheumatoid factor on somebody without the patient having the findings of rheumatoid arthritis can be very wasteful in many ways, because you get a positive rheumatoid factor and the patient thinks that they have rheumatoid arthritis because of that. But there's a list as long as your arm and leg of all the other reasons why somebody might have a positive rheumatoid factor. The same anti-CCP antibody tends to be more specific for rheumatoid arthritis, but again, it's not totally specific. And the bane of rheumatologists' lives when it comes to antibody testing is anti-nuclear antibody tests. Over the years, the sensitivity of these tests have become quite high, but the specificity is very low. And when a study was done a number of years ago looking at antibody or anti-nuclear antibody test positivity in people who worked in immunology labs, the anti-nuclear antibody test positivity was quite high, and all these people were very healthy. So it's important to know why you're ordering these tests and how to interpret them. And oftentimes we get a marginally positive, or low positive anti-nuclear antibody test result, and you're there scratching your head because you know the patient doesn't have lupus or any of the other conditions where anti-nuclear antibody tests are positive. Now, next slide. So the next step, when you have your history and your physical examination and the laboratory test results, you put it all together and it helps you to make a diagnosis. For rheumatoid arthritis, systemic lupus, and ankylosing spondylitis, there are classification criteria that are used in making a diagnosis. And there's always this difficulty in understanding the difference between classification criteria and diagnostic criteria. Classification criteria are out there because people like to do studies on patients with different conditions, and not just in rheumatology. So if you want to compare patients in your practice with patients in your colleague's practice, you have to know that they both have the same condition. And this is where classification comes in. So if you're doing a study, patients have to meet certain classification criteria to be included. But you can have a diagnosis of a disease without necessarily having all the classification criteria that would make a patient eligible for a study. An example of that is these biologic drugs that we have been using for the past 20 years. They're very expensive, but when they were studied in patients who only had rheumatoid arthritis. They could not have another condition that would interfere with the assessment of their joints. So when we take our practices and look at those patients who are in those studies, the patients in our practices would only about 20% would qualify for a study. So the other 80% of patients in the practice who have rheumatoid arthritis wouldn't fit the criteria for a study, but they do have rheumatoid arthritis. So that's where classification comes in. But in making a diagnosis, yes, classification criteria are used, but you can still make the diagnosis. In rheumatoid arthritis and ankylosing spondylitis, the pattern of a joint involvement is important. The symptom duration and the laboratory test results are used, as I mentioned before. For a patient with a new diagnosis of systemic lupus, you also have to be careful to ensure that you've assessed the patient for other organ involvement, and that's where the history and the laboratory tests come in. And so these patients will have a specific pattern to their disease involvement. For patients with a known disease, such as rheumatoid arthritis, a thorough joint exam is really important in these patients, and the patient's blood test, particularly the inflammatory marker profile. If all of these tests are done and the patient is fully assessed and you're still not finding inflammation, then you have to tell the patient that they don't have an inflammatory arthritis. And it's important to do this because patients can be reassured that they do not have a potentially destructive form of arthritis. You also have to be to recognize that these patients do not have inflammation because they will not need to be treated with the medications that we use for inflammatory forms of arthritis, and these drugs can have significant side effects. And it also helps to direct the patient to a more appropriate treatment program. Next slide. So there's no evidence of inflammation, but why do I hurt? This is the usual and expected response from the patient. And how you respond to that question is very important. It's important to acknowledge that the patient's pain is real. It's also important to have the patient understand that the absolute answer to their question is not always possible. And it's also important to reassure the patient that you will work with them and help them to manage their pain. Unfortunately, there are situations where patients are dismissed when nothing is found to indicate that they have an inflammatory arthritis. And this is the worst possible thing, as far as I'm concerned, that a healthcare professional can do. Next slide, please. In patients who have joint disease, the pain that they have, which is not inflammatory, can be associated with a number of issues. So they may have joint damage from previously uncontrolled disease. They may have developed mechanical issues in their musculoskeletal system, which have occurred because they've had to adapt to doing activities using other parts of their musculoskeletal system that they would not have normally done. For example, a patient who has difficulty lifting a bag of groceries may start using their arm to lift the bag, hook the carrying part of the bag around their forearm and lift it, causing more stress across the elbow and shoulder. And then patients will come in with pain around the elbow, over the outside of the elbow, and can be diagnosed with conditions like tennis elbow or golfer's elbow, even though they'll tell you they've never played either. But the patient does not have an inflammatory joint disease. They have a mechanical issue associated with the way they have started to use their musculoskeletal system. Also, the same thing can happen if they have joint damage in a knee or hip. They can end up with back pain because they've adapted their gait. In some patients with newly diagnosed inflammatory arthritis, even though the inflammation appears to be under control with the medications that we use, there are nerve endings in the joint capsule, and these nerve endings can remain irritated for an extended period of time, even after the inflammatory process is controlled. And the other issue that can occur in patients who have inflamed joints who have now responded to treatment is that the muscles surrounding these joints can remain tight. So they have difficulty, for example, patients who have ankylosing spondylitis, you may have controlled their back inflammation, but they still have significant tightness in the paravertebral muscles, or the muscles around their spine, which needs to be addressed. That's why exercise is important, not just in our day-to-day activities, but for people with an inflammatory arthritis. They need to keep moving to help manage some of the muscle issues that can occur. Next slide. In new patients with no evidence of inflammation, as I mentioned before, it's important to acknowledge that the pain is real. Patients are often dismissed as being whiners. And that's the worst thing you can do for a patient, because that patient won't trust you anymore. They may even lose faith in the medical system totally and pursue other ways of managing their pain. I think it's important to acknowledge that you, as well as a physician or as a healthcare provider, don't have all the answers, and that you work with the patient to help them find answers. We know how pain is perceived. There was a Nobel Prize awarded this week or last week to the individuals who worked in this area. But the cause of this pain, as I've mentioned, is not always fully understood. And I think it's important that the patient is told this and that you acknowledge that you don't know the answer. And the other thing that's important to do is that you need to tell the patient that you will keep working with them and also continue to monitor them, because sometimes patients with an inflammatory arthritis, their disease can take a long time to surface, and they may have a lot of musculoskeletal symptoms before the disease becomes obvious. Next slide. So in new patients, discuss non-medication approach is the first thing. Yeah, you ask the patient, if possible, to avoid triggers for pain. You ask them to try and reduce stress, which is usually ha, ha, ha. The only people who are not stressed in this world are in the graveyard. It's also important that patients try to improve their sleep. Education about sleep hygiene is really important. And it's also important to acknowledge that there's not always an easy solution for patients. It's very important to have the patients understand that even though they hurt when they move, that inactivity is worse than not moving through the pain. So exercise is key in managing pain. It's key in managing the pain of non-inflammatory arthritis. It's also key in managing the pain of inflammatory arthritis. And there are programs out there that address a patient's needs, so it's important to know where these programs are available. It's also important that if they do go to a private institution, that they ask the person that they're going to work with if they understand what pain is about. If the instructor doesn't understand what pain is about and how to manage it with exercise, it's important for them to ask the instructor if they're prepared to learn with them. If they're not, the patient needs to move on. Some patients may ask if they have fibromyalgia because they've looked up, obviously with the internet, you can look up anything. Dr. Google has degrees from all over the world, so he can tell you anything. There are criteria for making a diagnosis of this condition. This condition has had many difficult discussions amongst healthcare professionals over the years. Some healthcare professionals think that it doesn't exist because there's no abnormalities, therefore there's no disease. And to me, that's an admission of their own lack of knowledge. Insurance companies are also reluctant to accept the diagnosis of fibromyalgia or even chronic pain because there's no blood test, there's no physical abnormalities, so therefore they don't want people swindling them out of their money. But there are criteria for the diagnosis of fibromyalgia, and these have been made available through the American College of Rheumatology. And unfortunately, this slide wasn't part of the ones that I sent to Jeff, so I'll just have to read them out for you or speak to them. The American College of Rheumatology in 2010 put out a preliminary diagnostic criteria set for fibromyalgia, which is basically widespread pain and symptom severity. In the widespread pain, they have a scale. In the symptom severity, they have a scale. And when patients meet certain numbers within those criteria sets, they can be diagnosed with fibromyalgia. And it's also important to understand that there are no other comorbidities or other diseases that might explain the symptoms that the patient has. So when we talk about widespread pain, patients have pain in their shoulders, patients have pain in their upper arms or in their lower arms, they can have pain in their hips, their legs, their jaw, their chest, their abdomen, or their upper and lower back or neck. And the symptoms that are taken into account when the symptom severity scale is being assessed are things like irritable bowel, patients complain of dizziness, memory loss, also known as fibro fog, blurring of vision, shortness of breath, cold hands or feet, dry eyes, dry mouth, seizures, rashes, and sun sensitivity. And when all of these, like seizures and rashes, are assessed, there's really no evidence that there's any abnormal brain activity. So why do I hurt? So this is, if you keep moving through the slides, Jeff, the slide is in response to the patient's questions. So in response to a patient's question, I advised them that musculoskeletal pain and fibromyalgia is a form of musculoskeletal pain. It's a label that may and will be problematic for them in their daily lives because there will be people out there who will tell them that it's all in their heads. And patients are quite surprised when I say to them, yes, it is all in your head, but that's where pain is perceived. But as you know, the comment that it's all in your head means that the patient is crazy. I reassure them that that is not the case. I also reassure them that there's no specific therapy for their condition. There are medications that are used, like low-dose antidepressant medications, which can help some people manage the pain that they have. Medication to help with sleep can be helpful in some people, but not always. And the management of fibromyalgia is similar to the management of pain in other chronic pain conditions. So in summary, not all joint pain is inflammatory in nature. It's very important to have a careful assessment of all patients, whether they are newly referred or they have established joint disease. It's really, really important to take a history and examine the patient carefully. And it's important that appropriate management is set in place for patients without enabling the patient. I think that it's really important. Jeff, this is the last slide. It's the summary slide. It's really important to help a patient, but not to tell them that everything that's involved in what they're doing is you're just enabling them to not deal with the pain. They have to be helped to deal with the pain, but they shouldn't be enabled in going looking for insurance coverage to take time off work or stop working or look for disability insurance. I try to steer people away from that because that's a slippery slope. And it's also important, and that's what I mean by supporting the patient. The patient needs to be supported, but not in the way that will have them give up on life. It's really important to keep people engaged and make sure that they try as much as possible with your help and with the help of your colleagues to deal with their pain.